Hello, in this video I'm going to be talking about margins in breast cancer surgery. This actually applies to all different kinds of surgery reports after cancer surgery. One of the first things that people will hear about when they have their surgery complete and the results are back in are what are the margins? And you might hear your surgeon or somebody on the surgeon's team say the margins were clear. What does that mean? It sounds kind of complicated, but it's actually pretty simple and straightforward and really important. When surgery is done, the tumor is removed by the surgeon and a little bit of normal tissue around it. We used to expect and want much wider margins, that difference between the edge of the surgical specimen and the tumor. But we've since learned that if we can avoid having tumor right at the margin, that's actually good enough for local control. So let me back up just a little bit. A surgical specimen is taken out of the body and sent to the pathologist. The pathologist will look at the specimen under the microscope. And the edge, the difference between where the tumor ends and the edge of the specimen ends, is called the margin. We like to see no tumor right at the edge. We want to see no tumor on ink. So that's really the criterion for a negative margin in invasive cancer. In ductal carcinoma in situ, or DCIS, stage 0, we actually like to see a little bit wider of a margin, 2 millimeters. It's really narrow, but that's because ductal carcinoma in situ can have some skip patterns, and we want to make sure that all that tumor is removed and we're not seeing a little bit sneak through. And also because the main concern after surgery for DCIS is local recurrence. So let's talk about what a negative margin means. When a margin is negative, as I mentioned, it means there's no ink right on the edge of the tumor. And that is associated with a lower likelihood of the cancer coming back in the surgical bed, in that breast, or another part of the body if you're having surgery for a different kind of cancer. When margins are negative, which is what we like to see, it sounds like it's a bad thing when we say negative, but when margins are negative, it is associated with a lower risk of recurrence in the breast, but not a zero risk. It's important that nobody tell you that this will guarantee that the cancer won't come back in the breast. And this is why people with negative margins are still advised in most cases to follow up with radiation therapy. If there's a positive margin, it means there's a tumor right on that ink, and there's a higher likelihood of the cancer coming back in the breast itself. This is not associated with survival outcomes, but it is associated with local recurrence risk. With a positive margin, if it's possible, the surgeon will often offer or recommend a re-excision to try to make sure that a completely negative margin is achieved. So it doesn't guarantee that the cancer will come back, but it's associated with a higher risk, which is why the surgeon is more likely to offer a re-excision. There are a couple times when re-excision can't be done. If somebody's tumor goes all the way up to the skin or involves the skin, basically the margin has fully been excised, so there's no re-excision done. And if the cancer goes all the way up to the chest wall, and the fascia, that is the sheet of it's sort of a shiny tissue, has been removed already, there's no need to go back to achieve a better margin. So when the tumor's right up and involving the skin or all the way against the back of the chest wall, a re-excision won't necessarily be offered, but radiation therapy, including a boost to that area where the tumor was, is likely to be offered to somebody with a margin that's positive that can't be further re-excised. What if you've had a mastectomy? Positive margins are really uncommon, although sometimes it's up to the skin or the back of the chest wall. The other thing is that positive margins don't affect the stage of your cancer. So your stage won't change if the margins are negative or positive. The margin status does not determine your cancer stage. If you're interested in knowing whether your margins were positive, negative, or close, I'd invite you to go to Yerbba.com and get your personalized Yerbba report. This will tell you all the things we know about your tumor based on medical records that you've given us access to or have uploaded. And we can create a report that will tell you everything we know about what you've had done, your treatment options, the pros and cons of each. And one of my favorite features of Yerbba is that it gives you a set of questions you can ask physicians based on the results of your surgery and other findings that have been done. What about for close margins? So you may have heard that term from friends or other people you know going through treatment, or that's what you may hear on the phone after your surgery when your surgeon or the surgeon's team calls you to talk about the surgery results. A close margin sounds really challenging, and for ductal carcinoma in situ, it can be. So that's where that 2 millimeter margin is preferred. In invasive cancer, if it's close, that means that the tumor might come close to the ink that the surgeon has put on the tumor when they remove it, but it's still a negative margin. Surgeons who've been operating for a long time may be used to the previous recommendation of 5 millimeters or, a margin of 1 centimeter. So if it's less than that, they may refer to this as a close margin. But really, it's either a negative or a positive margin in invasive cancer. And in DCIS, we really like to see that 2 millimeter margin. I've covered a lot. If you have any questions, I'd invite you to re-watch this video or to check out our other videos about surgery. Thanks so much for watching, and we'll see you next time.